All right, I'm gonna just get started with Steve's introduction. So Steve Vinson is here from the Michigan Medicine Senior Financial and Business Group. So he is the Senior Financial and Business Analyst for Michigan Medicine's Medical Group. He has been leading the University of Michigan Medical Group DEI, or Diversity, Equity, and Inclusion Committee since March of 2017. Due to his efforts leading DEI initiatives, Steve was the recipient of the Office of Health, Equity, and Inclusion's inaugural DEI Advocate Award in April 2018. Steve co-wrote the UMMG Committee's mini grant proposal for their DEI driver program, receiving an award for 2019. Steve is also a member of U of M's Voices of the Staff, Advancing Diversity, Equity, and Inclusion team. He has collaborated on many projects with the Office of Health, Equity, and Inclusion, including panel discussions, DEI workshops, and national conference presentations. Today's presentation was created upon request by the Michigan Medicine Compliance Department this June after discussions about the disproportionate impact of COVID on minority groups. And we've asked him, Brian Toll, myself, have asked him to kind of do a pathology edition today. So this will be an interactive presentation. We'll have some breakout groups and polling, but I'm going to turn it over to Steve.
Thank you, Amanda, for that great introduction. I appreciate it. It's a pleasure and an honor to be with you all. Thank you for having me today. I'm just going to share my screen here so we can get right into it. So, oops, sorry about that. We're here today to talk about COVID-19 disparities and some of the underlying causes with respect to why we're seeing disproportionate rates in minority populations. I like to start off this presentation really with a quote from Dr. Martin Luther King Jr. when he talks about, I am sure that none of us would want to rest content with the superficial kind of social analysis that deals merely with the effects and does not grapple with underlying causes. When he said this, he was in a Birmingham jail cell, and he was talking about protests, but I thought it was really relevant for the topic that we're talking about here today. So we've heard probably on many occasions about how minority communities are being affected disproportionately with respect to COVID. It is widely believed that systemic racism is at the root of that cause, but really, what does that truly mean? So the session today really attempts to explore some of the systemic racism elements and define aspects of racism that really kind of go into some of these disparities. We're going to take a deeper dive into a few of these elements and explore how they have increased negative COVID outcomes for Black folks, Indigenous populations, and other folks of color on our journey today. If you have any questions, please ask. You can submit those questions via the chat. Brian, Amanda, and Lisa will be monitoring the chat function as well. Really just hope to have a fun learning session and share in a very comfortable environment. I'd like to start out with some national statistics, and let me just preface by saying that a lot of our comparisons today will be focused and based on Black versus white populations, and that's mainly because of the prevalence of data, the ease of finding statistics and data with respect to those communities. We know that COVID cases, we have race demographics with respect to about 50% of the COVID cases and about 90% of the deaths. And it's been difficult to find statistics for Indigenous populations. But in terms of some of the national disproportionate rates, Black deaths nationally are nearly 2 times greater than their share of population, about 25% to 13%. White deaths from COVID-19 are lower than their share of population in most of the states in DC. And again, Indigenous populations are also impacted at a higher rate. Again, we don't have a lot of data on Indigenous populations, but New Mexico, for example, they're 9% of the population, but 60% of the cases. With respect to Michigan, the Black and Latinx percentage of the population is about 20%, yet they're 39% of the cases and 43% of the deaths respectively. Looked at another way, looking at COVID death rates nationally by age and race. And these are rates of death by 100,000 population. And you can see across the spectrum, if you look at these different cohorts of decade years, the Black and Hispanic rates of death are significantly higher than the white population. But even broken down further, individuals who are a decade older for the white population has a less of a death rate than their Black and Hispanic counterparts who are 10 years younger. And that's across the spectrum. So for every decade cohort, a generation, I'm not a generation, but 10 years younger for the Black or Hispanic population, they have higher death rates than their white counterparts. We're looking at the state of Michigan. Overall, deaths by race, the white population, you can see, has more deaths, total deaths by race than the Black population and other demographics. But when you look at deaths per million, you can see that the Black rate is about 4 times higher than the white deaths per million by race. So you can see significant differences in terms of the proportion of cases and deaths across the racial spectrum. So this is when we're going to transition to a breakout session. We're only going to do this for about 4 or 5 minutes in groups of 3. We're just going to talk about some of the systemic issues that maybe you have had conversations about, what you're familiar with respect to disparities between minority populations and the majority population. We'll come back in about 5 minutes and hopefully return back to those discussions a little bit later on in the presentation. So welcome back, everyone. Hopefully you are able to have some good conversation. And again, I think we'll have an opportunity to get back to that conversation a little bit later on in the presentation. I like to really talk about racism and define racism, at least how I see it in this presentation. When we've thought historically about racism, we think about maybe racial prejudice, racial bias, racist interactions. And while those are definitely, that's definitely one form of racism, we look at organizations and systems, social systems that can really uphold racism and the reality of racism. So I like to define racism, being the finance guy that I am, with an equation and looking at racial prejudice in addition to social and institutional power. And it kind of has a cyclical relationship between the different types of racism, starting with internalized racism, which are race-based beliefs and feelings within individuals. And that can look like basically someone feeling that their specific traits, their way of doing things, their methods of handling situations are better than another race's strictly because of their race. Going to now interpersonal relationship, which is basically bigotry and biases shown through words and actions. And that can manifest in terms of exclusion from teams or clubs, social situations, and basically saying that this individual should be excluded because they're not a good fit, and basing that on their race. Institutional racism, discriminatory policies and practices within organizations and institutions that could manifest with respect to termination rates. If the termination rate for your underrepresented minorities is double that of the majority population, or your higher rate for the majority population is double that of underrepresented minority, you may want to look at some of the policies and practices within your organization. And then moving on to systemic racism, which is ongoing racial inequalities across institutions maintained by society. And we're going to take a look at those today in our presentation. So the first variable I'd like to look at is systemic racism. With respect to systemic racism is economic variables. So living conditions in some of these disparate communities are densely populated areas. You have many multi-generational families with grandparents, great-grandparents living in the homes. So more, at risk with respect to COVID and catching COVID cases. You look at affordability and access to healthy foods. You've heard perhaps of the term of food deserts, food insecurity, but really what we're also looking at is nutrition insecurity. Even though some of these neighborhoods might have lunch programs, if you've seen the food that is distributed, it is not very healthy. And then if you do have access to healthy foods in these areas, for a lot of these individuals, it's just not affordable. So lack of affordable and healthy foods leads to decreased health and wellness. And lastly, I'd like to talk about quickly the wealth gap between Black populations and white populations. And obviously, the more wealth you have, the better prepared you are, the better you can mitigate some of the challenges and outcomes with respect to COVID. And I'd like to just give one example with respect to wealth gap in terms of the Black farmer, and going back a little bit in terms of history. In 1920, Black folks owned roughly 14% of the United States farms. And so you had about 920,000 Black farmers. In 2020, Black folks own about 1.5% of US farms. And the number of Black farmers has gone down to about 50,000. And a lot of that is because of racism. We're talking about a century of racism. Some of that, or a good portion of that, is due to government programs. The USDA funds farmers with crop loans and so forth. So they distribute funds, and those funds are often allocated at local levels, determined by banks. And discrimination really could play, or did play, an impact in terms of farmers and the loans, the crop loans that they get, the timing of the crop loans. There was a class action suit against the USDA in 1999, and a settlement of $2 billion was distributed to thousands of farmers because of discrimination, and it was the largest civil rights settlement in history. Estimates show that the lost wealth of these Black farmers in that decade was between 175 to $225 billion. So that is just one example of wealth and how that gap has been created over the last several decades. And I'd like to transition now to a poll, if you would. So we're going to do a poll and ask folks about wealth gap. And we're talking about assets over liabilities. If the average white family has 100 in wealth, what does the average Black family? And I'll give you all about a minute to answer that. We got one more person who hasn't voted.
It might be me because I don't know how to get myself to vote, but I'll vote for someone.
No worries. So there you go. So all the tallies are in. Actually, the answer, it looks like the majority of you all voted 58. The answer is $10 out of 100. So about 10 times more the white wealth is. 81 is actually the gender pay gap between women and men. 58 is the pay gap between Black folks and white folks, but the wealth gap is actually 10%, or 10 times greater. So thank you for participating in that. And so how do we get wealth, right? What are the channels to wealth? Home ownership, business ownership, marriage, inheritances, and education, which is our next topic. So I want to show you all a graph or a graphic related to assets of children born in 2001. So this graphic looks at advantaged homes in terms of assets, total wealth, and disadvantaged homes by race. So the green would be the more advantaged homes in terms of the assets. The tan to the brown would be disadvantaged. And you can see children born into the white and Asian homes were significantly more advantaged compared to some of their other minority populations. And this really impacts, I think, education at a younger age. At around 9 months, most children in terms of child development skills are about even. We start to see clear, significant disparities by the time we get to 2 years of age. And so a lot of that has to do with the parents being home, spending time with the children, the education level of the parents, spending time in the resources that they have to develop their children and teach them at a younger age. So already we're starting to see at the early stages, disparities starting to exist with respect to education. And then we start to move into the classroom. So there's a research study that looked at some of the preschool classes in 2014. And in one study, Black kids were about 18 to 19% of the preschoolers, yet they represented about 50% of the suspensions of these classes. And it even went to show that some of the teachers were looking out for some of these Black kids to act out. We're expecting more behavior issues with respect to some of these Black kids, and often you find what you're looking for. And then moving on to middle school, secondary education, many of these inner city schools just lack the resources that some of the affluent schools have in terms of supplies, in terms of technology, in terms of the building, the infrastructure, and even the safety of the schools can compromise learning and education. There was a study that came out in 2019 that showed between 1890 and 1960, about 25 billion more in education funds were spent on more affluent white public schools than Black public schools. And so again, that provides an education a disadvantage. And then moving on to colleges and universities, a lot of the minority communications just don't have the financial safety net. A lot of these children and kids have to work while attending school. They don't have the same social support system. So really we're talking about the whole spectrum of the education process, individuals trying to overcome various barriers. Moving on to housing discrimination, which has been a big systemic element historically. So redlining was a practice that really was started in the 1930s. This was a common practice, government FHA-backed really system of discrimination that provided housing to white families in the suburbs, which relegated Black communities, other minority communities to urban housing projects in more poor neighborhoods. And basically, mortgages were refused in any sort of, or refused to be insured in any sort of urban neighborhood. Subsidized basically builders who were mass producing subdivisions and suburbs, and with the provision that none of these houses in these suburbs were sold to minorities. In Grosse Pointe, our own Grosse Pointe in Michigan here, they had a system in the 1960s called the Point System. And this was basically a screening process by a private investigator that looked to assess potential buyers in that neighborhood. And this was backed by the Grosse Pointe Business Association. So points were awarded for social identity things like the religion, the accent, their employment, who their friends were, those sorts of things. This process was basically looking at how Americanized individual buyers potential buyers were in this neighborhood. If you were of Northern European descent, you did not have to go through this process. Other ethnic individuals did. Polish individuals had to get, I think, 55 out of 100 points in order to be able to buy. Southern European had to get 65 out of 100. Jewish had to get 85 out of 100. If you were Black and Asian, you were not eligible for this screening process. And if a real estate agent did sell to a person that did not meet the criteria, then they would forfeit their commissions from the business association. Blockbusting practices, which ended in the 80s. But basically what that was real estate agents who would basically sell low to white individuals with the, basically they would communicate to these white homeowners that an unseemly element was coming in. You have racial minorities that are going to be moving into your neighborhood. You have to get out quickly. So they would sell low, and then the same real estate individuals would sell high to minorities looking to escape overcrowded inner cities. So this was, again, a practice that was very prevalent in the 60s, 70s, and 80s. Other housing discrimination, racial covenants was a common practice in the 1900s, and subprime loans, which is a big practice, very prevalent in the Great Recession time, that also disadvantaged minority communities. Environmental issues. So where is the housing for these individuals? Where is it located? So proximity to environmentally unsafe businesses where we have poor water and air quality. So a lot of their housing for these minority communities are close to refineries, they're close to landfills, power stations, which have higher pollution, higher ozone levels, and this really compromises, I think, the health and ability to stave off infection diseases. In fact, poor air and water quality, some research has shown that it has even a greater impact on COVID negative outcomes than some of the health disparity data that we've been looking at. Cap and trade policies. So these policies have really, some of them have enabled some of these companies to meet basically minimal standards without incurring any sort of financial accountability in terms of the environment. And in fact, the current administration has basically rolled back, I would say, about 2/3 of the climate conscious policies that previous administrations have enacted. And then lastly, when you're talking about some of these neighborhoods and some of these environments, they lack the physical activity spaces that we see in some of our affluent neighborhoods. So parks, trails, recreation spaces, fitness centers, yoga studios, right? Bar, Pilates studios. Many of these types of health and wellness places just do not exist in many of these communities. So also leading to, I think, negative outcomes with respect to COVID. And then lastly, healthcare indicators. And I'd like to just really start this section by reading a quote from the National Academies of Sciences, Engineering, and Medicine from 2017. And they say, health inequities are a result of more than individual choice or random occurrence. They are the result of historic and ongoing interplay of inequitable structures, policies, and norms that shape our lives. So with respect to lack of access to healthcare facilities, historically Blacks could not go to many of the white hospitals. The hospitals that did see the Black patients lacked the resources, they lacked the training and the personnel capable of giving top-notch healthcare. In addition to that, we're seeing, I think today, even with some of our skilled nursing facilities that are compromised, and we're seeing higher cases in many of these that lack the resources. Additionally, lack of transportation, that's the biggest reason for no-shows here at Michigan Medicine, and we talk about e-visits now, which are becoming much more popular. Do these communities have access to technology to have a virtual visit? Lack of insurance. Minority populations are about 2 times more likely to be unemployed, and health insurance comes along with employment. In addition to that, these minority communities have higher prevalence of jobs that do not provide health insurance. And in fact, many of our southern states has not expanded Medicaid, which is a big provider, big insurer for many minority populations. Lack of trust in the health system, bias in medicine. Studies show that minorities have less trust in their health systems, in their providers. And often that's because many of the providers just don't look like them. So that really undermines preventive care. Many of you may have heard of the Tuskegee syphilis experiment in the 30s. It really went on for about 4 decades, which was an experiment that was done on Black folks. They thought they were receiving kind of free community care, but in reality, untreated syphilis was being tested upon them. So again, this went on for about 4 decades, from the 30s to the 70s. And then looking at some of our underlying health conditions. So this is the mortality rate for Blacks and whites in Michigan from 2018, mortality rate per 100,000 individuals. And you can see at the bottom here, the mortality rate for Black individuals is about almost 1,000 per 100,000, which is about 30% higher than the mortality rate for whites. But what I've tried to do is highlight some of the causes, indicators that have shown to exacerbate COVID impact. And you can see that the mortality rate for Black individuals in these kind of areas is much higher in some cases. So we are going to transition to our second poll, if you would. Lisa, and this question is going to ask, out of all the causes that we just discussed, they have something in common. What might that be? The major elements of the Civil Rights Act of '64, major areas of social determinants of health, 5 campaign issues of Jesse Jackson in '84, or voted by millennials as the social issues where they differ greatest with baby boomers. So I'll give you all about a minute for that too. All right, looks like all voting is in. Well done, Pathology. I would expect you all to get that. So perfectly, almost perfectly done. They are the major areas for social determinants of health. So well done on that poll. Thank you for participating again. So yeah, and I think it's important also just to point out that these variables intersect, right? And it's a multi-layered effect. And these variables really have a huge impact in terms of our health in a negative way or a positive way. So I would like to open it up. This is an opportunity for audience participation, and would just like to have a group conversation about some of the other areas of systemic racism that I did not cover in the last several minutes. And maybe we can open up some of the conversations that you all had in your breakout rooms as we talk about some of the many other areas with respect to some of these disparities.
Yeah, thank you so much, Steve. That was a really great overview of kind of a lot of really broad issues that I think have been brought up in pieces and parts, at least over the last 10 years. But I don't think, at least for pathology, we haven't had anything really bringing it together with COVID. So I'm really thankful for that. One thing we were talking about in our group, my concern is access to testing. So if we're not getting good testing and not getting good data, then how are we supposed to really be able to make thoughtful decisions off of that? And I know even here for the community within Ann Arbor, it can be difficult to get tested. So my question kind of for the group is, how can we make testing more available and accessible within some of these communities.
So I don't know what the barriers are to our testing. I mean, some of it initially was capacity in terms of, do we have the appropriate tests? Very frequently, things will quickly come down to money in terms of, who can pay for all of the resources, the staffing and things like that. And, particularly in this kind of pandemic, if you want to be ideal and offer the testing, to be available to anybody, the easiest way to do that theoretically is to have it free. But then that comes back to money in terms of who someone's got to pay for it, type of thing. And so I don't know. I mean, this is where I think our public health system, has been largely decimated as far as funding is concerned, because in the past, one would have expected the public health system to do this. But,
Yes.
most public health officials that I've talked to, I mean, they're lucky if they can even maintain their current budgets, which are deficient, already and things like that. So, I mean, longer term things is, can you develop a test, that's similar to, say, to the, commonly, you buy it in the store pregnancy tests or other things like that. And that's going to take some while to really work out the technology for that. But it shouldn't be discounted, because we have, in fact, made some progress in some of those areas. I remember the only time you could get a pulse ox measurement was by going to the hospital. Now you've got those agents
everywhere
and similar things that are available to a lot of folks. But, you're talking years and things like that. But I think pushing those things and really trying to push to sort of really get more control of health status measures in the hands of common people is probably a good thing. You're still going to have expense issues. I mean, just to give an example, I don't know what the current price of a pulse oximeter is. I bought one some time ago before the COVID, crisis. But now I'm told the prices have gone up, they're probably $30, $50. And, for me being a, full professor at U of M, that's no big deal. But, to someone who's working a marginal job, that is a big deal, type of thing. So those are some of the things I think we have to deal with. I would also broaden this, because right now our focus has been on COVID testing. But, as Steve Vinson put up the slide in terms of a lot of the other chronic diseases, to really measure those effectiveness of what you're doing with those chronic diseases also involves testing. And again, there's the expense again. If you're going to really do something about diabetes, you've got to test blood sugar, you've got to test hemoglobin A1C, and you run into the same issues, there. If you don't have insurance, who's going to pay for it, type of thing. And so, again, thinking of ways that we can, either through grants or either through more funding, offer this to more people, particularly those who need it, who otherwise wouldn't have it, I think it's something that we need to deal with. And then the final thing I'll mention is that, there's a substantial health education piece around testing. You're talking about a general population, not just among African Americans, but I think among a lot of people, particularly poor people, I see this, that are suspicious of testing. I mean, they feel like, okay, a couple of things. One, why are you wanting to test me? Is this just another way for you to make money as a health system? What's the importance to me? Two, what do I do with the information? Three, maybe this testing is going to come up with some bad news. I see this in the context of things like, testing for breast cancer or testing for, colorectal cancer. I think as a human nature type of thing, we have a tendency sometimes to say, but if I don't test about it, then I won't know about it and maybe I won't have it. Now, unfortunately, that's the Trumpian philosophy, unfortunately, but, I think a lot of people, have that attitude, and so we have to chip away at that. I mean, what I try to say to people is that, look, you really should test for these things. Yes, I understand that you may find some unfortunate information, but frankly, the fact of the matter is the data, the situation is there. The only person who's in the dark is you, as to whether or not whether or not you have a colon cancer or don't, things like that. So if you do have something like that, when you prefer to know something about it at an early stage, when you can do something about it, as opposed to waiting when you can't do anything about it. But that's a learning piece. That's not something that's natural that people are with. But we could be doing much more, I think, again, as pathologists, in terms of doing that kind of general community health education about disease processes, why hypertension can do so much damage and be totally asymptomatic while it's doing that. That's where we should be weighing in, not just with COVID testing, although obviously that's what's on everybody's minds right now.
Yeah. Yeah. So for those that don't know Dr. Gordon, he is one of our favorite professors here. He works with the residents in autopsy, and he also does cardiovascular pathology. He's worked to start the DEI everything here at Michigan and Michigan Medicine, and has worked at Pfizer and done research. And he did a whole session for us a couple weeks ago, which is on YouTube if anybody wants to tune in and hear his full story. But I'm glad you could join us, Dr. Gordon. And he's working with the residents to directly address some of these issues. So there's a student, medical student-run free health clinic that we're going to be working with, and there's some grants within CAP and Pfizer addressing racial disparities. So those are just a few things that are starting to come up within the department for DEI.
So thank you for sharing that, Dr. Gordon. You brought up some really great points with respect to health and trust in the system and you know, already existing kind of mortality rates and so forth. I think COVID has really just exacerbated many of the problems that we've already really recognized. Do others have any other kind of areas of racism that you've discussed?
Hi, my name is Monica. I'm a medical student. I just wanted to say thank you to Dr. Gordon for bringing all those up. I think the budgeting issue with public health is certainly a problem. And I just wanted to share kind of what we did at the Ochsner Health System here in Louisiana to kind of get testing to those people who really need it. We actually implemented this research study which used, I forget the exact term, but basically we used a company that does targeted ads towards certain demographics of the population. And because if we offer a ton of free testing, say $1,000 of free testing, it's likely that the percentage of people who get these tests will still be predominantly white, access to cars, transportation, and time to get this testing done. So in order to make a more efficient use of, say, these $1,000, we really wanted to target this testing towards a demographic that represented New Orleans. So in order to do that, we use this like advertisement-based company which knows the demographics really well. And they actually advertised this test in a way that it tried to get a representative sample of our population in order to better understand, like, okay, say, again, I don't really know the exact statistics here, but say Louisiana is 40% Black. It tried to target and adjust the testing so that 40% of those people who came to get tested were Black. So I thought that was a really unique and interesting way to kind of use modern technology to get a better sense of what's actually happening in the community, instead of, obviously there's still a part of, you know, public health where we have to offer testing to those who really want it and access it, let it be asked to everyone, but there's a part where we can kind of help guide that data towards something that's more representative and get a better idea of what's going on in our community.
Thank you for sharing that, Monica. That is a great kind of innovative, I think, strategy, and those are the types of, I think, ideas that we need if we're really, you know, tackle some of these disparities in systemic racism.
Hey, Steve.
Oh, go ahead.
Steve, I just want to add one thing which may or may not be systemic racism, but getting down to just the logistics of the testing, which obviously our department does, depending on where that public clinic sends their tests, they don't necessarily send them to Michigan Medicine, even though they might be in Ann Arbor, adds time. There's transportation time. So if they're sending them to the central lab for the state in Lansing, there's travel time involved. I think where that gets exacerbated is the turnaround time for that information. So there are situations out there anecdotally where someone got tested, maybe in a minority community, and their job depended on them showing up, and yet they were being barred from that because they were either exposed or they were at risk because of some reason. And the test comes back like 10 days later. Well, that's basically the quarantine period. Yeah. And for other socioeconomic groups, I think that is more of an annoyance then critically linked to their economic well-being. And so whether or not it's intentional racism, there are inequities in the system of just getting the test results back so you can act upon them in this particular case. So I think those are the variables that we're experiencing throughout this epidemic, that information is so powerful, and yet for some groups, it's taking a long time for them to get the information that they actually need and act upon.
Yeah, great point, Brian. Thank you for sharing that. And then Angela, it looks like you were about to say something. Dr. Elam. Seems like she's gone now. All right. Well, thank you all for sharing. That was a great discussion and contributions. A couple of others that I just really thought about. We don't have time really to get into them, but employment, the types of jobs that these individuals in poor communities have, really frontline jobs that really expose them to COVID and catching COVID cases. Terrorism, domestic terrorism, we don't have time to go back to that, but systemically and historically, that has really impacted the wealth gap that we're seeing, policing and the prison system, which is a high, obviously, proportion of cases are in the prison system, political structures, social factors, infrastructure, and technology. All of these kind of play into systemic racism impacting and marginalized communities. So I just want to transition now to a couple of kind of race-conscious policy social changes that I think are needed to help mitigate some of these disparities with respect to our social determinant of health areas. Again, access to affordable and healthy foods. We need some bold public wealth initiatives. Monica talked about also kind of an innovative strategy as well. Reparations is something that's been talked about in terms of eliminating that wealth gap, which 30 years ago it wasn't, even though it was brought up, it wasn't really a serious conversation. But a city in North Carolina, Asheville, has actually agreed to distribute reparations to some of their minority populations for business development, for housing, and for economics, and also increased wages, paid leave, and benefits. Housing, we need to monitor the predatory practices we talked about. More affordable and accessible housing. Avalon Way, which is in Ann Arbor, has just created about 70 affordable housing projects in Ann Arbor for disadvantaged communities. And we need more kind of innovative ideas like that, and maybe looking at, again, intentionally desegregating communities. In the healthcare industry, eliminating bias in medicine, training and education, some of the work that Dr. Gordon does. We talked about improving financial and physical access to healthcare, increased care coordination. I know that many companies and even the Congress is investing millions, if not billions of dollars into looking at health inequity, which is something that needs to be ongoing. With respect to education, cancellation of student loans, which is a platform of some of the more progressive candidates that we've seen on the presidential level, investing in schools, technology, more diverse teachers, and more diverse curriculum. There's an initiative in Detroit called Connected Futures, which is businesses have donated about $23 million to Detroit public school students, giving them tablets and months of access to investment in neighborhoods and environments, government and business investment, improved policing relationships, and improving air and water quality. Harris County, Texas, just passed a $2.5 billion bond for flood issues, which is going to be distributed to their socially vulnerable communities, rather than historically that those sorts of bonds and those funds would have been distributed to their more affluent communities and residents. So these are just some, I think, some policy changes that could help mitigate some of these disparities overall, and then trickling down to COVID. Why is it important to call this out now? I think a lot of us are just more open to understand, to listen with an open heart, with an open mind. And I think when you force folks to kind of confront this issue, sometimes they'll become defensive. But I think ignoring or misidentifying these problems, I think leads to an excuse and to not address them. And lastly, I'd just like to end with, I think the assertion that personal choice is impacting racial disparities with respect to COVID, I think that's inaccurate. I think folks of all races are make poor choices with respect to COVID and their health and wellness. But I think when you look at the disparities, I think racism is at the heart of that and not race. And then lastly, again, kind of going back to the cyclical nature of racism, how can we as individuals take some actions that can help eliminate some of these injustices in some of these disparate communities? And I think individually, the first thing we can do is just go on a personal education initiative, take steps to educate ourselves in terms of what we're reading, documentaries we're watching, podcasts we're listening to, and intentionally complement the education, the standard education we've received in schools. I think it's important for all of us to help change the narrative and kill negative perceptions. When I was coming up, the term welfare mom was something that was used, and I think we just need to kill some of these negative perceptions, call out misinformation, but yet call in people and individuals to help educate. I think we need to pay it forward, model anti-racism for our children, younger generations. I think they're going to be much better prepared to deal with some of the inequities. And then lastly, get involved. It's voting day. I'm sure many of you have already voted or are going to vote today, but we need to vote at all levels, particularly the local level, because it's those individuals that are going to impact our lives on a daily basis more than sometimes the national, federal elections. Get involved, activism, our community health services. We talked about COVID testing. Our CHS department did COVID pop-up clinics in some of our minority communities. Getting involved, and United Way has done a great job with respect to some of the equity challenges, if you're familiar with that group. So these are some of the things I think as individuals we can do to help some of these injustices. And with that, we have a few minutes for any final thoughts, any questions that folks have before we close today. And you can put them in the chat box.
Yeah, so I have one comment, which I think is, kind of a mindset in terms of how we as healthcare providers approach health. I remember some years ago listening to a group of people who had gone to Cuba. I've never gone to Cuba, but they have a different, what they said was that they have a very, very different mindset. And by that, I mean this. Our health systems basically focus on taking responsibility for those people who walk into our door, and typically they have health insurance and things like that. We don't take the approach of saying we are responsible for everybody in our community, which is what supposedly the Cuban health system does, as an example. I'm sure they're not the only one, but that makes a big difference, because then, what you're doing then is to say, look, I've got to go and find out what, Sadie, who's maybe 70 years old and no one's seen her and she hasn't walked into our clinic, I need to find out what her health status is. And I need to be able to interact with her and try to, do something about that, regardless of what her race is, regardless of what her religion is, and things like that. I think if we took that kind of a much more public health, proactive approach, that would go a long way towards, dispersing, a lot of the things that we have as inherent racism. This is going to get rid of it, but at least we've adopted an obligation to say we've got to take care of everyone. Now that's within our capability. Hey, we're a richer country than Cuba is, and so it strikes me as ironic that Cuba has been able to pull this off, and I think in many cases, if you look at public health statistics, a lot of their citizens have better health outcomes than we do, but that's something that takes a lot of cooperation. I have a thought as to how to start that. I think you could start with a partnership between your federally qualified health centers and your public health system, and basically take that whole, say we are responsible for this population in this zip code. What are we going to do about it? And that, I think, would go a long way towards, dispelling that. And in the course of that year, you're going to learn about different people. You're going to learn that, so-and-so who's Black and you've, stereotyped as being, a gangster who's not interested in their health. Well, that ain't true. As you get to know that person, as you struggle with trying to get that person, healthy and find out what makes sense to them. So that's just a parting thought. Tough to do, but not impossible.
We can do it.
I think that's a wonderful way to close, Dr. Gordon, and thank you for sharing that wisdom. And I'd just like to end with a quote, and I think it is really kind of connects with what you're just saying, Dr. Gordon, from James Baldwin. If I love you, I have to make you conscious of some of the things you don't see. And I just think that right now we're in a time where we have to bring awareness. And I think we're seeing a little bit more love these days, and folks are more open-hearted and listening. And a little bit at a time, I think that will lead, in addition to what Dr. Gordon just shared, lead to remedy and healing in these public health spaces. So with that, I'm done. Thank you all for having me. It's been a pleasure and an honor. And thank you so much. It's nice to meet you all.
Yeah, thank you so much, Steve. This was amazing. And tomorrow, at the same time, I'm going to try to use the same Zoom link. We're going to have a debrief. I will also send out the recording for this. If you want to share it with anyone, they're welcome to join our debrief tomorrow. And that'll be at 8 a.m. But if everyone just wants to kind of start thinking about some of the things that we talked about today, share them with kind of your coworkers, your friends, your family, and then we'll kind of come back tomorrow and talk about everything. Does anyone have any questions or concerns before we conclude? Doesn't seem like it. So I hope everyone has a great day.